member of the Center for Embedded Network Sensing. So let's welcome our two speakers.
Applause beforehand. Thank you. Well, hopefully we'll get applause afterwards, too. Well, thanks to everybody for coming. I'm thrilled to have opportunity to share some of our learning experiences in the collaboration that Nithya and I and Mary Jane Rothram and Deborah Estrin, who are our two fearless leaders, have been working on the past 4 or so years. And so today's 2 talks are really going to be focused on kind of big picture issues around methodology, but not statistical methodology, more like data collection and study design issues. And some of the infrastructure related stuff around cell phones specifically. And then next week, Scott will follow up hopefully with some data from one of these pilot studies that I'll talk a little bit about and some statistical analyses. So I'll just start off by giving due credit to where credit's due. All of the pretty, beautiful slides with great pictures come from Nithya's group, from the computer scientists. And anything that is basically an outline with just text and boring is from me. But I love these slides and I love presenting them as sort of the big picture vision of this kind of mobile health paradigm. So we can use the mobile devices to enhance our health and wellness by expanding health interventions and research beyond the reach of traditional clinical care. So basically this photo here is showing, we can take data about our weight or about our location, or even with peripheral biosensors. This is like a blood glucose measure, or our diet, what we eat, or our sexual behaviors, or anything else. And we can provide self-reports about it. We can photograph our food, for example. We can give some reports about it. We can report our mood, our medication adherence, our sexual behaviors, whatever the domain is.
That's a very large hamburger.
Yeah.
I assume that's a hamburger.
It does look like it. That data can be part of what we might call an experience sampling stream that might go into what we might call a personal data repository or a personal data vault. Because this is very intensive personal data, there's a big concern for privacy, plus the computer scientists, to their credit, are big privacy advocates as well. That data can also be processed in the cloud, right? And can be aggregated at the population level, and we can do event detection with it on both the population level and also on the individual level. We can process the data, we can feed it back in visualizations, both for individuals, so I can get visualizations of my own personal data, and also visualizations for, say, managing population level data. And then that can all sort of get feedback into a loop. And there's some other pictures that describe this in more detail or more broadly. Basically, data collection, most simply, data collection on the phone. Oh, we made it. Great, come on in.
Thank you.
You're sure. Okay, let's move the table over to the side.
Okay.
Okay. You forgot cups?
Yeah.
Okay. Yeah, or we can get him at the break. Yeah. Do you need me to sign anything?
Huh?
Do you need me to sign anything?
Oh, that's it.
Okay. Shall we break for food now, or do you guys want to wait for a break in between the talks? Wait? Yeah, okay, good. So in short, we can collect data on the phones. It can go up to the cloud. It can be given dashboard access to individuals or researchers, public health officials, etc. And it can all be processed with data analysis, and we can do privacy preserving storage and things like that with the data. Here's some other stuff we can do. Once the data is processed, we can do location and time triggering of surveys and other kinds of information. We can do automated or background data capture through like the sensors on the phone, so by GPS or accelerometer, also audio and acoustic data. And this example here, which has been one of the main areas we've been working on, has been physical activity and diet for one of the pilot studies, actually that Nithya got one of the challenge grants for. We can infer actigraphy or infer basically physical activity, running, walking, biking, or being on a bus, because the combination of the accelerometer and the GPS location trace gives you if there's movement and gives you if there's movement on the body and movement across space.
There's accelerometers on, these are on cell phones?
On all smartphones there are accelerometers these days. So any Android, iPhone has accelerometers. And then another kind of innovation that we came up with were these different kinds of buttons. To be able, basically individuals can self-launch, self-initiate their surveys. So when I have a food event, I might be instructed to launch my food survey. Or if I experience a stressful event, I can just press this stress button and it'll mark the time and location of my stressful situation. And I might go in sometime later and annotate that event with a descriptive. Because at the time of a stressful event, I may not be able to stop in and do a text on my phone about what's going on in that moment, but later on I can come back to it. And this is based on user feedback from some focus groups and preliminary studies we did about wanting to capture when and where a specific event is happening, but not having the time in that moment to be able to annotate it or describe what's going on about it. Okay, some other pictures. Again, the end user dashboards, we're really focusing a lot on the self-monitoring and self-management components or possibilities, potentials with this technology. So this would be, say for a self-monitoring context, we can graph our actigraphy over time. So this would be a day of the week or and time of day. By location, so we can get location traces on Google Maps, for example. And we can do correlations by time and space. So we might record a sexual encounter, for example, that is recorded at a time and location, and then we could pull up a visualization. We could zoom in on that event and see the data associated with that event. We might be able to start to see, in terms of self-reflection as an individual, patterns in our own behavioral routines. Where and when certain events are likely to happen or not likely to happen, where we're on target with a behavioral goal or where we're off target with a behavioral goal. Okay, and then these are examples of other kinds of visualizations that are going to be happening on the phone. So the prior visualizations were web-based. So if you have a bigger screen, a tablet, or a computer, you can get kind of bigger visualizations. On the phone, it's a little more challenging, but there's great visualizations. These are mock-ups that the team has come up with, right, Nithya? Yeah. So here we have like, how are you feeling? How filling are your meals? So overeating data. Purple is too little, green is just right, and blue is too much. We might then say someday be able to kind of click on the too much and see the events of where the too much overeating is sort of happening, for example. Or sleep quality, sleep progression, and moods. These are all domains that we feel really apply to everybody, including people with HIV, although that's not what we're really assessing on the pilot study I'll talk about a little later. What else can we talk about on this slide? Configuring, what is this one about? Configuring?
Or being able to select what you wanted to see on your phone.
Right.
So think about these little widgets.
Right, widgets. So there's a big emphasis on personalization, on user interface design, on it's very burdensome data collection to be reporting these kinds of things on a multiple times per day, daily basis. So we have to do a lot of work to try to make it engaging and useful to the users so that they stay engaged and provide data, and that they find the data useful. And then here we're kind of bringing it up to a broader level. So there's researcher dashboards. We can get population level statistics for all the participants in a campaign or a research study. One of the things people are interested in tracking is what our participation rates are like, what our completion rates are like. And also, this slide is a little hard to see, but basically survey creation on a web interface. So as a researcher in the future, in the near future, I or or you, Dr. Schilling, would be able to go onto a website and we'd be able to author our own survey. It'll convert it into an app that downloads into the phone, and we won't need to have the programming team that we would have to pay to basically program a survey for us for our research purposes. So that's the goal, and I'll kind of revisit a lot of these topics as well. And then, of course, because of the personal nature of this finely grained individual level data, there's a big emphasis on privacy protection. So we want to be thinking about a personal data vault, which would basically be like an electronic medical record or electronic health record. So the mobile app captures the data. The mobile app can provide reminders. It can provide feedback and incentives. That can flow into a personal data vault. And then the vision is that individuals can selectively choose to share which data they want to share with different kinds of, say, providers. So I might want to share some of my mental health data with my mental health counselor that I wouldn't necessarily want to share with my physician for some reason, or vice versa. And so that's basically a filtering kind of a process where I as a user can define how I want my data to be filtered. I could also adjust the granularity of the data, meaning that I might want to not provide the finely grained detailed data on my location traces, but I might be more willing to provide kind of aggregated location type data. It's a little abstract depending on the user application. Anything to add, Nithya, do you think? No? Okay. So this is an acknowledgement of all the folks that are involved in putting together the studies that have led to the slides beforehand. Of course, Nithya here. And then we have a lot of collaborators, or they have a lot of content domain expert collaborators. So Bob Bilder in psychiatry, and there's, of course, Scott and me and Patricia Gans, who's a cancer researcher, and other folks around. And there's lots of different funding sources as well. So now I'm going to get into the boring slides. Well, actually, there's one more cool slide here. In addition to individual level data as a client or a research participant or a patient, we can do the same kind of data collection, monitoring, and feedback for providers of interventions. There's a lot of work going on with this right now with community health workers in global scale-up of health programs. And so by using mobile phones, you can get good monitoring data, but you can also use it to support for supervision and decision making in the field. What these two pictures show these are screenshots from a phone that a community health workers in South African townships doing prenatal and postnatal home visiting intervention use. And so what happens is when they go into the house, they click the phone and it starts to mark off the time that's elapsed during their visit. And at the end of the visit, they tick off which of these 8 core topics they discussed with the family. Now there's 8 hours total time here, and that's for 4 2-hour prenatal home visits. And there's 10 hours of time here, and there's more domains to address because it's the postnatal visits. So what this would give me as a researcher when I look at this and think about it is I can get really great fine-grained data on dose and exposure to an intervention, which we would use for as treated analyses as opposed to the intention to treat analyses. As a supervisor, I can go and I can look and see on a particular visit which topics were addressed and which weren't. And I can then discuss these individual visits with this kind of data with my team, with my staff, with the community health workers to provide decision-making support. So the examples that are given might be, well, at this visit we talked about HIV and alcohol, but we didn't talk about any of the other topics. And so we might, as a supervisor, I might say, well, so what was happening with the family at this visit that you couldn't talk about the other topics? Oh, well, they were really in crisis because somebody had just had a positive HIV diagnosis or had a positive HIV diagnosis, and they were struggling with alcohol abuse with a domestic partner. So then we'd say, okay, that's great. So you really met their priorities. On the next visit, you want to see if you can get some of these other topics in per the intervention protocol. So it can also allow a little bit more flexibility in intervention delivery. This is a slide or a screenshot from Mobenzi.com. Mobenzi is an open source platform for community health workers. It's come out of South Africa, and it's actually this company that has been collaborating with our projects with these home visiting projects in South Africa. There's another company called Demagi.com that does similar kind of work and actually has many more examples of global health scalers. But I just love this slide because it shows what's happening. You can have your data collectors and your health workers with their mobile phones. That data, including GPS location information, is kind of uploaded into the mobile researcher, which is their kind of web-based system, and get exported for data analysis. And also, researchers can design and manage the surveys that would get pushed to the phones. This data goes up to the cloud. What does API stand for again?
Application Programming Interface.
Application Programming Interface.
Allows the software to talk to another piece of software without a person in the middle.
Got it. So it's automatically processed. There are these open source consoles that are web-based. So the program staff can manage, so supervisors can manage the staff. They can check in on participants, and they can check the process, the delivery of interventions, and so forth. Basically supervision through web. Right, so it goes out here to the web browsers. Here's the supervisors. And then this sort of flows back into visit schedules, that kind of pushes back out information to the data collectors and the CHWs about what their next goals should be for the next round of data collection or the next home visits or whatever. Now there's another loop in here as well that's not shown, but we could have a whole other loop of individual participants or patients providing data in addition to the health workers and data collectors having data. So we could have these kind of multiple levels of data, of nesting of data. And it doesn't all have to be smartphone based like some of the earlier screenshots. This is a simple feature phone that this is the Mobenzi software on, basically like kind of a standard sort of, I don't know if it's the simplest text messaging phone, but kind of the next step up from a very basic phone. Okay, so what's some of the methodological background that informs this kind of research in this whole domain? Well, there's the convergence of three disciplines. The experience sampling method, which I like the term of, I keep coming back to it in our learning experiences in this work. It really comes out of psychology and quality of life research. And there's a book by these three authors, Heckner, Schmidt, and Csikszentmihalyi. Okay, Csikszentmihalyi. Parallel to this, actually subsequent to experience sampling, ecological momentary assessment is another term that's used. It's basically identical, and that's also in psychology. And the big names in that are Stone and Schiffman, and then Josh Smith is one of their students who's doing some great work as well. So if you ever want to search on some of this stuff. And then also ambulatory assessment is another term that basically describes the same thing. This ambulatory assessment comes more out of medicine and more from European researchers. And it's sort of characterized by using biomarkers a little more. So cortisol or blood pressure or other kinds of peripheral devices or other kinds of peripheral tests that a participant would either be triggered to do or instructed to complete. So
these three methods the same, you said?
yeah, they're all basically interchangeable.
Like different information?
Depending on who you read, these guys say that these guys basically just rebranded experience sampling as ecological momentary assessment and are defining it as experience sampling without any ambulatory assessment, without any peripheral devices. But the bottom line is, it's all the same, just different scholars are using different names because that's kind of what we're incentivized to do. We're incentivized to create a new method and give it a new name and say how different it is from the previous method, when really it's just all the same thing. But if you're ever doing any searches, if you're ever reading anything, they're all pretty much the same. EMA seems to be most commonly well known these days. I would say followed by experience sampling, and this ambulatory assessment stuff is a little harder to come by. Like I said, it's kind of more in the European literature. Okay, so there's sort of two broad types of data from this kind of method. Participant involved or participant generated data is how I've kind of been thinking about it. This would be self-report surveys, brief open-ended reports with annotations, which would basically be some kind of text response. Digital still images, video, audio, and then associated annotations if we want. So some studies would say take a picture and then write a little something about it, annotate it, tell me a little story about why you took this picture or this video. And pretty much everything can be time stamped, date stamped, all this data. And where possible and appropriate, we can also get location data, location stamps for the data. And I'll talk more about that in a minute. Then the second kind of data is the unobtrusive and low burden data. What this really means is stuff in the background. So for example, location, which we can get by GPS, ideally, on smartphones for the most part. But you can also do cell tower and Wi-Fi triangulation. So, but basically we can infer mobility and location from this kind of data. Accelerometers built into the phone, I mentioned before, we can infer activity, movement, exercise, even sleep roughly. You can kind of infer like that the first time a phone sort of moves or is activated might be like when a person is waking up and starting their day, depending on how integrated their phone is with their daily routine. And when there's no activity on a phone, you can kind of infer that there's some sleep happening, or at least there's restfulness. Depends on if they're carrying their phone or not, like I said. And very exciting new stuff that Nithya's, one of Nithya's students is developing that I'm really excited about would be audio sampling in the background. And this is really micro audio samples. So acoustic sampling of the environment. What that means is like, say every 10 seconds, a little snippet of audio is sampled through the phone's microphone. And from that, we might be able to, and hope to be able to, infer mood or tone in the surrounding and other environmental inferences. And what we know so far from other kinds of experiments done with this kind of really cutting edge type of data, background data collection, is that we have the ability to kind of detect voice versus, say, television or radio in the background. And possibly even my voice versus your other people's in the room's voices and things like that. So this is really new, but this is kind of like a new thing that we're developing. And then also you can get like call logs and SMS text messaging logs off of phones. And then finally peripheral devices that could be connected either by wires or by Bluetooth or other kinds of connection. Biosensors like blood sugar detection or blood pressure, heart rate, or whatever else anybody who has kind of more medically inclined peripheral devices. Yeah, Scott?
Hey Dallas, so I noticed that the audio sampling sounds really cool.
Yeah.
I noticed you even have privacy preserving up there.
Yeah.
Do you know what mechanisms are being put into play to protect privacy, like overhearing conversations?
Yeah. So the main thing is really that it's a micro audio snippet of sample. So first off, there's two ways it's preserved. One is that you're not having a continuous stream of audio over more than a second. It would be subseconds or seconds, somewhere in there. And then those would be spaced out every 10 or 20 or 30 seconds, or possibly randomly over that period of time. So that actually is the privacy preserving piece. So you wouldn't actually get any content of a conversation. You'll just kind of hear the tone. You know, if I'm yelling and screaming at my kids, you'll be able to pick that up. That's kind of the family-based context is what has sort of motivated the interest in this developing this kind of data collection. There's folks at oh yeah.
Which might be relevant here, which is that the other thing we're doing, because in our data collection we found that actually even 15 seconds of data, you can end up picking up some embarrassing things about people. Not usually, so for the most part it's true. But so the second thing that we're doing is we're actually doing a lot of the analysis on the phone itself, so that what we upload is a series of what we call features. I don't know if that translates to biostats, but essentially characteristics of the data stream. Statistic that we calculate on the raw audio stream. And so we upload those features because that's ultimately what we care about anyways. And you can't reverse engineer the features into what was actually being said in the raw audio stream. And so that's the other thing that we can do to just kind of make sure.
Yeah, that's great.
Features versus content.
Yes.
Right.
What about the fact that this is not really random? Because you have a phone. If I was yelling at my kids, I would put the phone in another room because I know that's being sent.
Maybe.
You'd be surprised how much we forget. I mean, I develop on these platforms all the time, and I agree explicitly at 5 p.m. I'm leaving the lab, and I'll say, sure, I'll run that audio sampling algorithm for you. I go home and I'm talking on the phone, I'm, complaining about my colleagues. I totally forget from the phone I play.
Yeah, and I think human nature, like communications and stuff happens more, I think, naturally. So when you have an interaction with your child, it's kind of like automatic. So when you have an argument, you want to say, hold on one second, I'm going to go and get my phone back. So I think when stuff happens more, like it goes more naturally, I think.
Yeah.
We're not gonna.
Yeah, when you're in the moment, oftentimes you don't remember to, I better turn the phone off. And then also in the background, the fact that you recognize it's not actually capturing any of the content of the conversation, just data. But it is definitely it's an issue. All of the data sharing and kind of anonymity and privacy concerns is something that we constantly address, particularly with qualitative methods from user feedback kind of interviews. Call logs, SMS, text messaging logs, people interested in social network analysis, things like that. This is like a great source of data. And there's a group at Boston at Harvard, Sandy Pentland's group. Yeah, so they're doing a lot of this kind of data in particular, and actually also getting like people's credit card records, and then like kind of making inferences based on like call logs and SMS logs and credit card transactions. Interesting stuff. And the other thing about the micro audio sampling as well is that by taking these snippets, a big issue is battery power on the phones. So you couldn't possibly have the phone recording audio continuously. It just drained the battery too quickly. So there's all these kind of battery power preservation methods that the computer scientists have to deal with. It's a big challenge all the time, right?
I think the unobtrusive and low burden data, I think this is a very interesting and promising complement to our traditional way of, for example, asking people questions. So I think this could be, for example, accelerometers. You can ask somebody, hey, did you exercise today? Somebody can say, yeah, I worked out for like 30 minutes. You can kind of verify whether that was true by this unobtrusive data, which they may not even realize was collected. So if the accelerometer says 0, then
right.
You could kind of infer that that person was kind of overestimating his physical activity.
That's right. You kind of have some built-in kind of validity and reliability checking. And so that is one of the things that we're doing actually is we're collecting this background data while also asking people questions about the data so we can kind of see what level of agreement there is between the sensors and their self-reports. So sampling schemes. So what we're sampling are events or experiences typically. That's what keeps, when we keep thinking about this and talking about it and planning projects and thinking about design discussions, ultimately that's what we have, that's the frame that keeps me grounded, is thinking about sampling experiences. And there's different ways we can go about this. We can do participant-initiated sampling. In other words, I'm instructed that whenever I experience an event, whatever it might be, a sexual encounter or an argument or a period of stress, that I will initiate completing a survey or providing some kind of data. Then we have different kinds of prompting. So time-based prompts. So I might specify when during a day I might want to receive prompts to complete a survey to provide the data, or location-based prompts. So for example, when I go home, I will get a prompt that asks me if I took my medication, because I'm going to only take my medication when I'm at home. And so this is all stuff that's come out of our studies with people living with HIV. And when we say, and actually when we set up the studies, we set up the phone, one of the first things we do is to help them establish the sampling scheme for them. Do they want time and or location-based prompts? It's all programmable on the phone. They select, oh, well, I want to do my medication report in the morning when I'm at home. So based on their GPS and based on the time is when they will get the prompt. Of course, there's all kinds of biases and things around this, in terms of statisticians and research design. We're kind of working in more of an interventionist framework. But we'll get to deal with these kind of issues as we start to do data analyses. And then there's other kinds of sensor database prompting that we could do as well, accelerometer or acoustic or other kinds of peripheral data. So for example, when my phone starts moving, that might trigger a prompt to complete a survey. Or if the acoustic data indicates that there's something going on, there's some loud kind of activity going on, I might get a prompt that says, hey, what's going on right now? Or what happened 10 minutes ago? Like after the acoustic data sort of mellows out and we see kind of a flat line, then I might get a prompt that says, oh, hey, it sounded like something, you just had some experience where there was a lot of commotion. Tell us about that experience. And then, of course, random prompts, which can also be linked to any of these other sort of data sources. And all of this stuff, most of the stuff we're doing in our pilot studies for completing surveys. And like I mentioned before, we could have this combination of time location prompts, and also we build in randomness to a lot of them. So a participant might specify a window, say a 3-hour window when they would like to receive, or when they would be most likely to respond to a prompt. And within that 3-hour window, it's randomly determined when they specifically get the prompt to complete a report. Or it could just be completely random. Usually, though, what we've been doing is, say, for experience sampling where we want to get 4 or 5 assessments a day, which is usually about the max that seems to be have been implemented in prior studies using experience sampling or using EMA. Kind of 4 or 5 times a day is pretty sort of common or standard. Then we'll specify chunks of time, say 3 or 4 hour chunks of time throughout a day, and then within each of those chunks, the prompt is actually randomly assigned automatically. Anything else we want to add on this? Okay. And so then there's the issue of the sampling frequency. So we need to anticipate the frequency of the experience to set a sampling rate for prompts or instructions for participant-initiated for prompts, or instructions for participant-initiated reports. In other words, well, I'll give some examples in a moment. So this could be, if it's in the moment, EMA type method. There could be a multiple times per day sort of near experience method, or a daily diary once per day method, or perhaps even more appropriate in some cases, weekly or more sort of short-term retrospective surveys. And so just some examples from our pilot study with people with HIV. We've been doing mood, which is basically depression, sadness, anxiousness, worry, also fatigue, tiredness, and energy. Those 4 assessments 4 times a day, because those will vary quite a lot potentially throughout a day. But medication adherence we're doing only 1 time a day, because most people are only taking their meds 1 time a day. Whereas sexual behavior and alcohol and other drug use that we're measuring, we're doing once a day on a daily diary. So it's just being reported for that for this day. But in retrospect, after we've actually collected the data, the sexual behaviors in particular are not daily occurrences. They're more like weekly occurrences. So we probably would have been better off doing a once a week assessment of sexual behavior retrospectively. Because if you're only having one event, it's happening during a week, and you're assessing it within that week, you'll probably get pretty reliable reports on the details of that sexual encounter. Now, if we were working, let's say we were working with a sex worker population, I might want to have sexual behavior reports multiple times per day. Now, we also instruct people that at any point, at any time, if they want to, they can self-initiate completing a survey. But that's sort of also unreliable, because people might choose not to, or they forget, or they're not motivated to. So this is kind of where we get prompted type reporting. And this ultimately brings me to the idea of some kind of adaptive assessment style, because there might be variation in your study participant population on the frequency of some events for some people. So some people could be, in our PLH study, for example, some people could be very sexually active for a couple days at a time, like on the weekends. And they might have 3 or 4 or 5 sexual encounters over a weekend. If we did that but only collected it retrospectively for a week, that might be hard to get that data for. So I think in the future we might want to be thinking about adaptive assessments, so that if there's a lot of no reports, then maybe we reduce the frequency of prompting to complete a report. And if there are yes reports, then we can increase the frequency of prompting to report on a particular experience or event. Any questions or comments? Okay. And then we get to reactivity, which is both a nuisance and an opportunity. So the EMA researchers have found in their reviews of EMA studies that about half of study participants, or half of studies, I should say, have participants who change the observed behaviors as part of the research study. Now, this is possibly linked to the recruitment setting or the study framing. So in discussion with Josh Smith, actually, a few years ago about this reactivity issue, he kind of suggested this, and he's actually published a review on this recently. But basically the idea is if you're working with anorexics and you recruit them from an anorexia clinic, and you're asking them to monitor their eating behaviors throughout a day, they're probably more likely to change their behaviors, say, than people that you recruited not in an anorexia clinic, because they're in a clinic to recover, to get well, to change their behaviors. So the whole frame of their clinical experience and even the frame of the study would suggest that it's there to sort of help them, as opposed to just collect basic data about their basic behavioral data for. But many EMA researchers aren't really interested in the intervention components or the behavior change components. They just want good data. So they see this reactivity as a nuisance because it potentially creates bias. And it's not just EMA, actually. There's an assessment effect that's been found in retrospective studies. So when we do our standard kind of retrospective behavioral research studies, we're doing an interview with somebody and we ask them every 3 months for, say, a year or 2 years, tell me about what happened in your previous 3 months. Well, control groups that have no intervention, actually also we see improvement in the key outcomes for the study based just on self-monitoring. And so there have been a couple of studies done that just look at self-monitoring as an intervention of itself. And then also we can get back up in the big philosophy of science stuff, Heisenberg's uncertainty principle and Schrödinger's cat stuff, which are actually things I learned about in my anthropological training early on.
Just a small thing that it bugs me. So
Yeah.
I've been on that particular point, we've been discussing it CCH for years.
Yeah.
And I ran across another explanation for the possible reason for the decrease, and that's because of the anchoring. That at the baseline interview, there's no anchor, and so you often, people pull in additional events that are more than, you're asking for past 3 months events, and they'll pull in because they don't have an anchor for that. But now the baseline provides an anchor. If at 3 months you ask for past 3 months, they only answer for the stuff past that.
Right.
And so that because of the pull-in, and I don't know why there's only pull-in and not push-out.
Right.
But, and that would explain also the baseline. We've had other explanations like what you just ran through for why there's more reported at baseline.
And then a lot of these assessments were asking the same questions over a period of time. So at baseline, I've had instances where they answer pretty honestly. So one example is like how many people in the social support you have. So you can report up to 10 friends, but then for each friend you have all these series of questions. So 3 months
You
later,
get
from
punished
10 friends, you
for
get
having
like
more
2
friends.
friends because they know that if it's say I have 10 friends, your interview time will be longer. So they kind of adjust their responses based on their previous experience.
Yeah.
And that's what now I call survey conditioning.
Right. So you don't know whether it's actually true or whether it's due to the fact that they know that more questions are coming, so they intentionally reduce
the number of reports. Yeah.
In the one survey I was on, the people were kind of over-eager to, they over-interpreted the first one. It was just basically a warm-up. Now that one, fortunately, there was monthly data for the first year, and so the fact that the first one was different, we could ignore it, but in some of these big ones where you're just doing 3 or 4 every 5 months or something, you can't ignore that baseline, so you kind of have to use it even if it's maybe people over-interpret. So there's kind of there's like 3 or 4 of these different things that all lead to the same thing, which is a large response for the baseline, then it calms down.
Right.
For any of these reasons.
So some key things to observe. Oh, Scott?
Go ahead. Oh, I was just going to ask, you may have already answered the question then, with respect to reactivity, then there's habituation to reactivity. Right. Because you were saying that somebody who's coming from an eating clinic, like an anorexia clinic, might report something for a while, report more information about that, but then after a while, that would have to taper off naturally.
That's what Jay's point was, the survey conditioning. They might taper off naturally.
And that brings in another one. So
We need the direction then, right? Either I'm reporting more food or less food. Yeah.
and another one that we found in analyzing, well, actually, it's built into the studies, but we often only allow in our HIV studies, you have to be risky. You have engaged in risky sex, you have engaged in drug use in the past 3 months, and that leaves out, omits people that have zeros. Then at the follow-up, 0 is possible. And so I know we haven't used that when we've done our main data analysis. We don't take that into account, but we actually have censored or data at the baseline or truncated. And so if we don't take that into account, it looks like a huge drop. And traditionally we call that regression to the mean, but it's actually omission of those zeros. And so when we take that into account, we just did that analysis for the HLP data that was viewed as work, and it's much closer than what we were seeing when we did the analysis. And it's still a drop, but it's not nearly as big as we were having to try to explain doing the analysis.
And I wanted to actually just throw in the anchoring point you made to start out with. That's why the method for collecting the data is so important. And there's something called the timeline follow-back method. And in that, even at baseline, we would try to provide a very clear and solid anchor for a 3-month assessment. So we wouldn't just say what happened the past 3 months. We would do what we would do at all the assessments. So thinking about the past 3 months, like what was a big event that happened about 3 months ago, putting it on a piece of paper, charting out significant events that happened since then, and then that's all kind of a cue for the memory to then report the report. So hopefully that would dampen that effect. But that's why it's important to have that kind of method when you're collecting the retrospective data. But also, I think this kind of mobile data will maybe give us some new insights into these kind of effects, because if we have, maybe not for a baseline assessment, but for follow-up assessments, if we're comparing retrospective reports to mobile data, we'll be able to get a sense of, how much sort of distortion or bias or forgetfulness or whatever there is in the retrospective reports, assuming the mobile reports are more accurate.
Yeah, assuming there are some studies. There are going to be a lot more because you do have the opportunity now. But there are studies of those sorts, and I don't remember what I found when I was digging them up. But people do the retrospective, and then they also have diary comparisons.
Right, that's right.
Maybe somebody else knows more of what those things show, but.
Oh, I was just going to say, I forgot the name of the principal investigator, but I know one attempt to address the reactivity problem that Jay mentioned, where you kind of get penalized if you say, I have 10 friends and you have to answer questions. They had another series of questions you were directed to if you answered fewer members of partners or friends. So either way, you still get forced to keep the survey the same length. So I thought that was kind of an innovative.
And then I remember when
that's right.
Followback presented this thing about survey conditioning, it becomes potentially problematic when participants kind of know what questions are coming, so it becomes a little more predictable. So he devised a scheme where the number of questions, the content of the questions are identical, but then the order in which the questions are asked is totally random. So instead of asking sexual behavior questions first, because they know, okay, they're going to ask me about sexual behavior, so I know what I'm going to answer, something a totally different section comes up. So it's kind of like, and then he did a thing where one was identical over time and the other was like more random, but the content the same, but the order is different. And then so the bias he concluded was less on the one where the questions are less predictable. So it was a little more honest. So different ways.
The mobile questions are more modular too, so it'll be interesting to see how that plays out.
Yep.
Dallas, one thing we haven't talked about here is the opportunity.
Yeah, I was just going to get back to that.
Oh, no, I
Yeah.
I didn't mean that. I
Oh.
meant the opportunity for this kind of data collection to take the interviewer. This has been implied, but to take we've all been there where we look at the data when it comes in, whether it's online or it's on a hard copy, and yeah, that's fine. And then we get around to entering the data, and then we see, oh geez, that interviewer decided to make it up as she went along.
Mm-hmm.
And so, and part of that, of course, has to do with just people sort of thinking, well, I know better, and even though you've had them well trained, they slip off that. And other times there's cues from the respondent that I don't like answering these questions.
Right.
And so, and of course, dutifully, the interviewer doesn't like asking those. So,
right.
So this gets around a lot of those kind of things that, at least in my experience,
It
those
does.
are some of my most painful memories.
Absolutely. Both in terms of having self-administered surveys, but also in terms of the real-time data transfer and review, if you set up the protocol right, by data managers or supervisors reviewing the data coming in from their field workers, which was actually the big thing that was happening in these kind of global scale-up studies in sub-Saharan Africa, and so that's how those kind of mobile community health worker things sort of came about. But there's also finally, I see this as, and many of us see this as actually an opportunity for interventionists. Regardless of kind of the biases and the reactivity issues, self-monitoring is a key behavior change tool. Kind of any kind of a self-management or other kind of behavior change plan typically involves self-monitoring of those behaviors. To know if you're on target, off target, to really get a better sense and handle on what you're actually doing, not what you remember that you're doing or what you think you're doing. And so we kind of came up with this term, ecological momentary interventions. And Josh Smith wrote a review on it last year with a co-author. So I think that's kind of where overall the vision is going for us, is data coming in. And then, well, actually, I think I have another slide that talks about it a little bit. But basically, data coming in, being processed, and then being fed back to the participant in some way for an intervention. Okay, so now, gosh, I just want to go through the mobile platforms quickly for the methods, because these are common questions that people have when we're trying to design studies. What kind of phones can we use? What does what? How does it all work? And so Nithya, feel free to pipe in if I'm off topic with any of these. But basically, the universal mobile platform, everybody has this kind of phone pretty much globally these days, is just SMS, so text messaging, or interactive voice response, IVR, which is kind of like movie phone automated voice stuff. So you get a phone call, and it reads you basically what you would read in a text message, and gives you multiple choice responses to be able to reply to, which is something I've had to implement in a study in India because of concerns about literacy, and if not literacy in the local language, then literacy of being able to read Roman text on a text messaging. And then also potentially multimedia messaging, so pictures and video. I'm not sure if it's universal on all devices now. It's not quite. But basically, text messaging and IVR are universally available on all phones, but they only have time-stamped data and time-based prompts. There's no GPS location prompts or data collection or unobtrusive data collection on these kind of simple, standard candy bar, $20 or $10 feature phones. And you also need an SMS or an IVR back-end system, which means something on a server somewhere, something that's running the whole program. And programming for anything but small-scale SMS applications. And I say that because one of our colleagues, Kathy Reback, has implemented a pilot study, a pilot intervention using text messaging, but it was with peer health educators. So it wasn't automated in any way. It was peer health educators interacting with their clients in real time. And what they were using was an instant messaging interface on a computer that was then being sent out by an SMS gateway. But they can only handle, so many people doing that. So the application that we have, that she has just put in, that I'm a co-investigator on now, if it gets accepted, would be to automate that system and compare an automated system to a health educator mediated system, and do some cost-benefit analysis on that as well. Okay, so the next platform that's broadly available, but not as broadly as the simple feature phones, would be mobile web, HTML5. I'm looking into the OK. So we get better user interfaces. Basically, this is any phone that has a web browser can use this platform. So it's a better user interface. It's more easily programmable. Basically, it's an HTML5 web page. You can get timestamp data and time-based prompts. Not likely to have GPS or location data.
Probably would.
It probably would.
If you're going to be using HTML5 supporting it, then it'll most likely have.
So it's just a matter of time at this point for programming development.
Yeah.
Yeah. Okay. So that was a specific thing for when your platform will have location-based prompts and data or not.
Yes.
Okay. Versus general. So HTML5 will support.
It's more just that the phones that are going to be supporting HTML5 will most likely have the GPS on them.
I see. And then if it's on them, then you can get the data.
And then, yeah, once our application.
Okay.
So HTML5 itself, it has something called phone gap that it runs with that will allow you to access the GPS.
Okay. Great. So that's great news. So it works on any phone with a web browser that runs HTML5.
Unobtrusive data collection part, that's a little tougher.
That one won't happen.
It's sort of a possibility.
Okay. So don't know yet. I think we're still working out how this HTML. I mean, this is pretty new, cutting edge stuff. So there's work to be done. Experiments to be run, and seeing what's really feasible or not. And it works on any phone with a web browser, although that's not entirely accurate. It's got to be an HTML5 enabled web browser.
It's going to be more recent.
More recent phones. So not quite yet universally available, but likely to be more universally available. And then finally, there's the smartphone app-based thing. So iPhone OS, Android is what our collaborations have been working on. That gives us the maximum options. So you can get time, location, GPS, all the unobtrusive background data. More technically involved programming, I think, especially for the unobtrusive data, the battery life issues, and so on. There's also app incompatibility across phones. So even if you have the same OS, so even if you're using Android, that app won't necessarily run on any phone that runs Android. And is it about screens, but it's also about, I think, the architecture in the phone as well.
And the software that's running on the phone, the actual operating system version.
Yeah, there's a lot of different operating system versions, right? So you have proliferation of OSs, of versions, right?
It's like Windows XP versus
Right.
Windows 3.1.
Got it. Okay. So most likely we'll have to provide phones to participants in any study, using apps. But also, we'll be getting researcher clinician authourable web interfaces that are under development, and you can check out homage.org, which is the collaboration here at UCLA that's putting that together. So that would basically take out some of the cost and burden and barrier of having to hire programmers to program your campaign or your intervention or your surveys. Okay, so validity and reliability is a major challenge recognized by mHealth innovators. There's a lack of gold standards for EMA or ESM type measures. There's limited examples of measures to draw upon at this point. And most are very specific to a particular research question. So for the example is, how many dimensions of mood do you want to measure? So when I was doing research trying to find measures for our studies, I would run across some studies in the past that had measured 15 dimensions of mood, and others that measured 7 or 10. And how many different ways do we want to splice up depressed, sad, blue, all those kinds of things, right? So that's kind of one of the challenges. So it's really chunking and splitting issues in the domains or categories that you want to assess. So my colleagues who do mixed methods research would say that mixed methods measure development is really the ideal approach. What that would mean would be kind of cycling with qualitative and quantitative measures, and really doing qualitative work with your participants that you're actually working with, to talk with them about what the domains of interest are that you're going to be assessing, how they define and categorize and operationalize them that reflect their experience. But that's also timely and expensive. And so the approach that I've been kind of taking is to adapt the current gold standard retrospective self-reports as the sort of quick and dirty approach. And then we have our pilot study with HIV positive people. This is the last slide or two, so we can have our break. We're recruiting from AIDS Project Los Angeles, which is a community-based agency in LA here. We've got 47 people since October, and our goal is to reach 60 through another site. So we assigned folks a G1 Android phone, so a first generation Android phone with the Homage app tailored for the important domains for persons with HIV to report on over 6 weeks. And so we took the CDC health-related quality of life measure that I think is standard, like a 2-week retrospective, and we basically just changed it to say, how are you feeling today, or right now, or for the past few hours. So we've got the sad, depressed, worried, anxious, energy, and fatigue. Medication use / adherence, people are prompted once a day. Alcohol, tobacco, and other drug use, people are prompted once a day to complete a report for that day. And then sexual behaviors, as I mentioned, we're doing daily, but we should probably be doing that weekly with this population. And then also, we have stressful events and photo diary that are self-initiated with annotation. And that's kind of reflecting this participatory approach that I really appreciate the computer scientists have been bringing to this type of work. But basically, it allows participants to say, you know what, hey, it's not just about the data we're interested in. We're also interested in data you want to share with us, or data that you're interested in collecting about your life. So it's kind of a user engagement strategy. I mean, actually many people have reported stressful events and photo diaries, and they annotate them. So we're seeing reports of things like a stressful event, like being at the doctor's office, or running out of money before the disability check comes, or something like that. And we're also collecting retrospective survey data at baseline 2, 4, and 6 weeks. And so those are for the previous 2 weeks. Tell me about your sexual encounters, tell me about your medication adherence, all the exact same domains, but for 2-week intervals. And we've randomly assigned to 3 study groups. One group is just getting surveys, no phones. Another group is getting the phones with the consent form and the instructions being framed as a new research tool, not really for behavior change support. And the third group is getting phones, and the study materials are framed as a behavior change support kind of pilot program. And that's to kind of maybe test this hypothesis around reactivity and the framing effects on study design. I don't know that we're really going to find anything about it. I don't think we had enough intensity of these instructions to make something pan out, but we might see something in the qualitative data. And the reason I say that is because our preliminary quantitative data analysis and actually qualitative data are showing that people are reporting, regardless of which group they're in, they're reporting that the phone surveys are helpful to them in managing their health behaviors, regardless of the group. And so our goals for this data were to get data for feasibility, especially given the privacy concerns, reliability with our gold standard retrospective self-reports, surveys, behavior change, reactivity or self-monitoring, and ultimately to inform a self-management intervention that would be based on, at minimum, self-reflection from self-monitoring and visualizations, but ultimately to do automated support messages based on pattern detection algorithms. So a participant would carry the phone, do some reports for a period of time that we might call a baseline period. It might be 2 weeks. And then based on that data, there'll be these kind of algorithmic pattern detection programs that would identify when and where specific events are likely to occur. And the system would send out automated messages anticipating when and where those events would happen again in the future. So on a Friday night is when I've reported risk behaviors in the past. In the future, I'm going to get automated messages on a Friday night that say, hey, remember your safe sex goals and to carry condoms. Or, just down the street is the HIV testing location, or whatever it might be for the population. Great. All right. Any questions? Yeah.
So, as a statistician, if we receive data that's collected through this mobile device method versus more traditional methods, what would you say are some of the unique goals that we would face when analyzing data that's collected specifically from mobile devices?
Well, I think that Scott is going to be addressing that next week.
Looks like it's a whole talk.
Yeah. This is.
Just really quickly, it's just some of the challenges are with all the data points, you have the potential to see patterns at a much finer gradient. But the challenge is also what to do with all the data, with all the data points.
Yeah.
Because usually you have a few individuals you follow over time. as opposed to most studies where you have a lot of individuals with fewer time points. So some of those issues are really different.
Mhm. I can say one of the, just from a few weeks ago, just some preliminary analysis that Scott ran that was really interesting and kind of encouraging was the mood and medication adherence association data. So we know from prior studies that medication non-adherence is associated with emotional distress, so anxiety or depression, and also with other risk behaviors, substance use and sexual risk behaviors. But that's all based on retrospective self-reports. So we don't know if it's a generalized state of kind of depression or of emotional distress or specific. And the data that Scott was looking at shows that it's on a daily basis. The association is there on a daily basis. So when somebody's reporting depression or sadness, it was depression specifically, wasn't it? On a specific day, that day they were more likely to have missed a medication dose. So that's the kind of, that's the kind of level of finely grained data and inferences that we'll be able to make with this data.
Bivariate longitude.
Well,
No?
no, I was just writing simple answers to your question.
But we'll get to the
Yeah,
bivariate.
that'll be the next thing.
You've kind of alluded to that, true breakthroughs are very few, and those of us who were around in the Pleistocene era can remember a line of inquiry, two states that come to mind, Kansas and Oregon in particular, and Washington, where later referred to as behaviorists, and essentially looking at behavior within the individual. And if you sort of look at the journals, you'd be hard pressed to find an article in the literature now, and yet you would literally, there were tens of journals circa 1970. And of course, a lot of this will be very helpful, this technology, to sort of pick up where that sort of fell on its own weight of it turns out that clients don't like collecting data. As a clinician, I can remember working with parents of difficult children, and you'd ask them to collect data, and I remember a Boeing engineer, he loved collecting that data. But for every Boeing engineer, there were a lot of other parents who said, this just doesn't fit with my data.
Right.
So
Right.
It's exciting stuff.
Yeah. And to that point, we would hope that the mobile phone being integrated into people's daily routines makes it so much easier to report and collect the data and get this unobtrusive data as well in the background and stuff like that. All right, so wow, we're 10 past. So we'll take a
5, 8.
5 to 10 minute break, get food and coffee.